Good afternoon. Welcome to another session of IJCCM Best Article of the Month, in which we have something on ultrasonography of the airway. And we have with us here the corresponding author, Dr. Supriya. So, would you like to tell us two things? Number one, how this topic interested you, and number two, what were your most important findings?
Yes, ma'am. Actually, in our setup, whereas I am working, uses of ultrasound in OT scenarios is rampant, but in difficult airway situation in ICU scenarios, it is not being used in a vast majority. So, to the best of my knowledge, I have not found many literature supporting POCUS point of care ultrasound for airway, particularly airway in critically ill patient in critical care unit. That's why we were searching for a topic to do using ultrasound for difficult airway assessment in critical care patients. And that is the first answer, ma'am. And the second thing which you told, that our findings, what is our findings? We took two basic parameters in ultrasound guided, that is skin to higher bone distance, and another is skin to thyroid membrane distance. And we correlated with Cormack-Lehane grading during the intubation. What we found, that skin to thyroid membrane, if it is more than the cutoff, and skin to higher membrane, if it is more than the cutoff, then it is definitely falling in the difficult airway category. And amongst the skin to thyroid and skin to higher membrane, skin to thyroid membrane distance is more specific and sensitive. This is our finding in this study.
Dr. Mahesh, you have gone through the study, so you would be able to give us inputs from your side.
Yeah, ma'am. Thank you, ma'am. First of all, I congratulate Dr. Supriya for going through a tough task. What I was realizing, you have almost evaluated 150 plus patients in your ICU.
Yes.
Very intubation, ultrasound, and assessment of airway. I mean, that is what I could understand, because most of the times we may not have enough time to evaluate our patients in ICU.
Yes.
I mean, two people assessing the airway with the ultrasound and documenting prior to the intubation, I'm sure it would have been a tough task. So that way, if you see, this study gives us some kind of inputs, which was not done before in ICU, where difficult airway assessment and obviously before intubation having an assessment would give us some direction to be prepared. One comment I would like to make, we all know all ICU airways are difficult, and we don't take any airway lightly, no matter whatever assessment, whether it is a clinical assessment or focus. But having said that, I also had a few doubts. How could it have been possible to do so many patients having so much of accuracy? I'm sure you'll be able to highlight upon that. So that is one point. Obviously, I would be happy to hear from Dr. Supriya. Anything you want to tell about that, madam?
Yes. So our study started from 2022 December to April 1st, 2022, and it covered both surgical and medical ICU. So, and it is a teaching institute where I am working. So we are getting plenty of cases. As it was not done, and here we are more focused toward ultrasound usage. Now it is upcoming branch in OT setup, emergency setup also you are using frequently. That's why we chose this topic. So the patient profile which we have got, we have almost 172 according to our calculation of sample studies. We calculated the sample size to be 172, but after exclusion it became 150. So in this period of almost 2 years, we were able to get this much of sample, that 150 sample, more than 152, we got that. And as we have taken the various parameter and we took the reference of the previous studies which was being done some comparison, some studies are there which has been done in ICU. Not this exact study was done. Some studies were done where we took the parameter of thyroid distance, skin to thyroid and skin to hyoid membrane. That's why we took those two parameters, and it was very easy to, and can be done within less than 2 minutes. And we didn't take our exclusion criteria also says for crash intubation we are not taking, for cervical spine injury we are not taking, pregnant patient we are excluding. Those who are in probability of intubation we took that case. And how we got these all these parameter, we have our it is a postgraduate institute, so PG students are there, and our esteemed faculty who are well versed with ultrasound, they are also very helpful. So we got this type this huge number of cases, and these parameters were accurate. And obviously the statistical measures we took that were also helpful.
I'll just ask one question there.
Yes, ma'am.
So is it possible that when you were doing the study, like you
Yes.
planned to do it in one patient and then you found that the time that it is taking is a little long, so you went ahead with the intubation? Was there any such patient, or as you said, crash you have excluded? So like this
Yes.
also, have you excluded any patient in whom it, because you said you had in the study you have said that 2 people have assessed and then you have taken the parameters.
Yes, ma'am.
So did you find any patient in whom you actually had to abandon this ultrasound procedure because
No,
of the time it was taking?
no, madam. No, madam. We were very, if it was any difficulty or any crash situation was there, we just removed it. We put it in exclusion criteria. We didn't went for that. That will create a confusion. That's why we didn't include.
And any patients were on vasopressors during this time?
Vasopressor, madam, few were there, but we didn't documented in this study. Few were there.
Dr. Mahesh.
Yeah, I think we can't generalize the study for all ICU patients. I mean, that is what
Yes.
we have to understand by this.
Yes.
Because if we say that it can be done in all ICU patients, then wasting time on focus probably will land up in disasters. So obviously, in a planned intubation or relatively semi-urgent kind of situations, when you assess a patient in the beginning itself, if you have a time as a part of routine screening, what we do, even neck assessment also can be done as a additional focus examination. I mean, that is what we can interfere probably.
Yes.
But same time, what we have to understand, this cannot be generalized for all our ICU population. Probably if we had a number of patients who were excluded, that would have been better. And what was the sickness of the patients also, if we had a better clarity, then it would have been still better. What was the Apache or SOFA score? I mean, these things would have given us still better direction to apply it more on, or do further studies on the same topic.
In fact, an RCT in which you decide that some patients you will do this ultrasound assessment. It can't be blinded, obviously. And in others, you do the routine, which means you just kind of quickly look at their, some other parameters like, obviously you won't go for a full Mallam patti, but something at least like you'd see the thyroid mental distance and things. So those are the things that if we had compared, maybe we would have been wiser. Yeah. Anything else, Dr. Mahesha?
Yeah, the other part, what I was seeing, obviously, going forward, like we have seen difficult airway guidelines kind of evolving over a period of time. Definitely, it's not a bad idea to have ultrasound assessment as an additional tool. Availability may be challenging in most of the ICUs at that point of time, because if we are running a say 50-bedded ICU, or like what madam will see 7,500 plus bedded ICUs, having 3-4 machines as a part of assessment may be difficult. But definitely the idea, we should be kind of applauding madam for coming up with a different idea in a ICU setup. Yeah. But inter-observer variation, biases, I mean, that is what we should be aware because how much ever skilled we are, probably getting a hands-on training in airway is not going to be easy. Especially if patient is breathing faster, getting all these evaluations. There can be even 0.1, 0.2 millimeter variations are going to change our statistical outcome.
That is
Yes,
the problem when we talk of very small values, this is this many centimeters, this point, this centimeter. So actually that is very right. I completely
yes, that
agree
is
with
very cumbersome, and that is user variability was there. So the ultrasound performed was by the DM critical care or fellow critical care doctors who are the teaching faculty over there. And I am also well trained, ma'am, because I am a trauma anesthetist, so I regularly do focus. But the ultrasound parameters were taken by the senior consultants who were well versed with the focus of airway. That's why, but that is definitely a gray area, and that ultrasound availability, what you told, sir, that is a big challenge, very big challenge. In ICU, every time to get an ultrasound, that is very big challenge. That is the gray area. Yes, I accept.
So what do you think? Suppose you decide that all my residents should get trained using the ultrasound in the airway in the ICU, not in the OT. So you
Yes, ma'am.
think what is the learning curve? How long do you think they'll take? How many ultrasounds do you think they should do before you think that they are good enough for this?
In the ICU, ma'am, more than 25 to 30 ultrasound focused on airway only. Then I can say that resident may be well versed with ultrasound usage and focus airway ultrasound they can perform.
Right. So yeah, competency based. If you go by competency based training, this is an important parameter that one should think of. Yeah. Dr.
Even
Mahesha.
if we see the values like thyroid membrane distance from the skin, whatever was calculated,
Yes, sir.
which seemed to be kind of overestimating, or it was kind of telling that difficult airways are more. But when you compared with the Cormack-Lane grading, it was much, much lesser.
Much lesser. Yes, that ROC curve showed that. In ROC curve, we got it is much more, but during when we did the Cormack-Lane grading, it was found to be very less.
Yeah, I mean, we accept like overestimating difficulty. I'm not sure whether it is going to add on more stress on ICU working people, but still, overestimating is probably not bad. I mean, that is one point of observation which I was making, that it was kind of telling that most of the airways were difficult, but when you compared clinically, it was coming to be much, much lesser.
Much lesser. Yes.
Chalo. I think that's enough, and we should quickly summarize. And maybe if you have a recommendation, each of you, one minute, you just tell us what you think based on this study. Dr. Supriya?
Yes, ma'am. So, for ICU setup in critically ill patient, ultrasound guided focus of airway is definitely a very good, less non-invasive, easy to use tool for prediction of difficult airway. And skin to thyroid membrane distance is a definitely better predictor for difficult airway by ultrasound. And student teaching should definitely include ultrasound uses of ultrasound focus in their regular curriculum, which is again dependent on the availability of ultrasound and the technical superiority of the faculties of that institute. So it should be promoted with regular workshops and webinar or seminars.
Okay, Dr. Mahesha?
Yeah, focus. I mean, any kind of focus without a question doing a focus is actually not very appropriate. So having said that, to assess a difficult airway, if focus can be used as a additional tool, then definitely there is nothing wrong. Probably it is going to get added on in coming guidelines in near future. Probably it is even for intubation assessment and post-intubation assessment. I mean, in all the fields, focus definitely will get at some point, but we should never forget that clinical assessment is also definitely much important, and we should not kind of lag behind in clinical assessment and only concentrate on focus.
Right. Thank you so much. Both of you have nicely summarized the findings.